think a lot of us were raised with the idea, don't use a lot, if a little will do. And that sounds like a really sensible approach. But when it comes to multiple sclerosis, how do you know that a little will do? Well, hello and welcome to another episode of You and Me and Multiple Sclerosis. My name is Pam and I've been living with MS for almost 40 years. Periodically on this channel, I've been giving you updates on what research is saying about multiple sclerosis, and terms get used from time to time in my videos, which I think I explained at the time, but after I think about it, I realized maybe I should do a video specifically on those terms and make sure that everyone knows what they mean and what the implications are. And in this case, I'd like to talk with you a little bit about the difference between what they call escalation therapy and induction therapy. And to put it quite simply, escalation therapy is the kind of time-honored way of doing things where you start somebody out on a medication that is no more risky and no more severe than it absolutely has to be. And if that one works, great. So you're doling out your MS treatment the way you might dole out toothpaste.
When it comes to toothpaste, you want to use a pea-sized amount. If your toothpaste is covering the whole top of your toothbrush, that is not a pea-sized amount. It should be a small blob toward the end of your toothbrush.
But if it doesn't work, then you escalate to a medicine that may carry more risk, but is more powerful. The other alternative would be induction therapy, where you start right out with the big guns. You take out the heavy artillery right away because you don't want to think that you're just letting time do more damage before you finally realize that the treatment that you're using is not being effective. Even though there might be some more risk, you just monitor for that. When I was diagnosed with MS and I first started having symptoms back in the 80s, the mindset of that time was entirely escalation therapy. And in fact, quite honestly, we didn't have a lot to even escalate to. But as more therapies came online later on in the 21st century, the discussion really got going about whether it was better to start somebody out on what they called a high efficacy treatment or to go with a more moderate efficacy treatment, which has fewer side effects. I'll play a clip from 2010 that captures the prevailing view at that time.
One of the things that I think the MS community is facing on a evolving basis is the idea that maybe we should be more aggressive about how we start treating patients, that maybe the idea should be that we hit them hard with immunosuppressive drugs early on and then consider putting them on something a little bit safer in a long-term fashion. I'd love to hear your thoughts about that approach.
Well, one of the difficulties about being very aggressive, particularly at the very early aspects of the disease, at least as far as I'm concerned, is we're probably going to get a fair amount of risk, perhaps for a reduced amount of long-term benefit.
So I think the issue here is induction versus escalation, if someone's going to change. And my concern about induction is twofold. One, I don't think we're smart enough yet. And in that sense, I don't think we're smart enough to figure out who's going to do badly.
But, don't be too rough on those folks. I think looking at that now, you think, well, they were pretty timid about things. They weren't very adventuresome. But you have to bear in mind that they didn't have all the data that we have now on how risks can be managed and how efficacious some of these treatments could actually be. They were just looking at the downside risks and the great uncertainties. Things have changed in the years since then. And several of the people that I follow on YouTube have championed this idea of induction therapy, going all out right at the beginning. As soon as you know there's something going on, hit it hard with everything you've got and hopefully stop it in its tracks. People that have been promoting that include Dr. Aaron Boster.
Generally speaking, we think about induction earlier on in the chronology of the human being's life. Medication is a tool, one of many tools that we bring to bear to help you live your very best life despite having MS. I have failed 0 times in finding a therapy that someone can tolerate if they want to be on a therapy. The only patients in my practice who are not on a therapy refuse to take one. And so it's my hope that you will be open-minded, and that even though early on in the disease process, you might not recognize what might come if you're untreated successfully, please trust that with medicine, we have revolutionized the history of this disease. We have changed the course of the disease by the earliest application of the most effective therapies. And so I want that for you and your family. And I want that for you 20 years from now.
Dr. Brandon Bieber.
If you have multiple sclerosis, is it better to start treatment with a medication that's not highly effective but is relatively safe? Or is it better to hit it hard and early with a highly effective but potentially risky medication? There are 2 main approaches that are commonly used. One, which was used in the past almost exclusively, was known as escalation therapy. With this style, you sort of start with a modestly effective agent such as glatiramer or beta interferon, and then only if you're not doing well, only if you have new lesions on MRI, increasing disability, or new relapses would you escalate to a more efficacious or riskier treatment. The other approach, known as induction therapy, may actually be the way to go, which is to just right from the bat take a highly effective medication and take the risk of side effects, just accept the risk of side effects. Even now, a lot of different experts are recommending induction therapy, including myself, and also Dr. Aaron Boster, who has an excellent YouTube channel, and also Professor Gavin Giovannoni, who has a YouTube channel and a popular MS research blog.
And Dr. Gavin Giovannoni.
Keep getting pushback from colleagues and others in the MS community for actually pushing or wanting to use immune reconstitution therapies very early on in the course of the disease. Even the regulators and our payers, the NHS, they've put a lot of barriers in place stopping us using the more aggressive therapies early on in the course of the disease. And this is the problem in the field. You know, we have these very effective therapies that have a opportunity of really making an enormous difference if used early, but we can't use them early, or we criticize for using them early, or we criticize for promoting their effectiveness. And I think one of the problems is we are blinkered by the fact that we can actually now render our patients free of inflammatory disease activity. In other words, make them relapse or MRI activity free. Okay, and we've satisfied our treatment target, and we ignore the data on the end organ damage that occurs on these therapies. We ignore the concept of smoldering MS, and actually we ignore the underlying pathogenesis and what we think causes MS and how we should be treating the cause of the disease. And I think herein lies the problem. You know, we've been blinkered, and we've had the wool pulled over our eyes by the new generation of therapies that are a lot safer, in inverted commas, and very effective at switching off focal inflammation, but don't tackle the root cause of the disease, and that's the problem. You know, and I find this very, very sad that the use of immune reconstitution therapies very early on in the course of the disease is very low, and actually getting lower. The use of alemtuzumab, for example, now is really a trickle of patients all over the world, and that's incredibly sad.
They all have excellent points. They all look at this in the same way. It really fills them with great dismay that so many doctors don't do that, and that so many people with MS go on to have more disability and more damage in their brains than they needed to have if they had at least been tried on a different therapy that worked a little more efficiently. Recently, I came across a really good explanation of this induction versus escalation therapy by Dr. John Corboy.
Ultimately, what this really revolves around is using a risk-benefit analysis at the various times in someone's life to come up with the best choice for them at that point in time, hopefully with a lot of benefit and the least amount of risk, or at least balancing the risk and the benefit. And we have, in a broad sense, 2 broad categories in terms of how effective the drugs are. And we can sort of lump them into moderately effective, choices, as listed there, the old injectable medicines and some of the oral medications, as well as the more highly effective therapies. And more highly effective therapies can be broken down in sort of a sense of those that are not highlighted here as more persistently being used. And then also highlighted in yellow would be those that we might use in sort of what we call an induction approach. And I'll have a description of that in a moment, so bear with me while I get to that. So one of the things that's on the list to discuss today is escalation. And we can use this in two broad senses. One, would we start with a moderately effective therapy and then escalate as needed? But then also, how do we escalate if someone is having more problems and or switch to an alternative? And for many years, because of the way the drugs developed, we only really had moderately effective therapies. And in fact, people would sort of go through those, the old Avonex, Betaseron, Copaxone, and Rebifs. And then as we got more highly effective therapies, such as Tysabri and Gilenya, it was a natural thing if you had already tried the other drugs and you were having still more difficulties or not tolerating them, to transition to the more highly effective therapies. And so in part, this concept that you would use a more moderately effective therapy first and then go to more highly effective therapy just simply represents the way the drugs got developed. And so the important thing in today's world, when someone is newly diagnosed, is that a lot of times insurance companies will have what they call step edits or fail first therapy approaches, where they will pay for drug A, B, or C before they will pay for drug X, Y, or Z. And these are made on financial decisions. These are not medical decisions. These are financial decisions. And so we fight our way through these because we don't necessarily agree with this concept of using a step edit. But the important point about escalation therapy is that it assumes that many people will respond and tolerate the moderately effective therapies. Unfortunately, that is just simply not the case. So for us, using this concept of escalation therapy is not really the way we think about things. But the basic principles about when you would escalate and when you would change medications, you'd think that we'd have maybe a sort of agreed upon formula or algorithm, but in fact, there's really no agreed upon definition of what is drug failure, at least due to secondary to lack of effectiveness or efficacy. But if we know that in newly treated patients, if you take someone newly diagnosed, they go on medication X, a number of studies have looked at whether or not you can predict after 1 year, with whatever has happened within 1 year, what people might look like 5 or 10 years later. And we do this in large databases, primarily from Europe, where they start people on drug X, they follow them over a course of a year, and then they follow them further a long time into this database. And you come back and you can mine that database and say, hey, what happened to people if this happened in the first year, if that happened in the first year, or if nothing happened in the first year? And from this kind of data, we know that things that are bad for disability later, 5 to 10 years later, are a relapse in the first year, 3 or more new lesions on your brain scan or an active lesion in the first year. Accumulation of significant new disability in the first year predicts more disability later. But interestingly, 1 to 2 new brain MRI lesions is really not terribly predictive of significant new disease activity. So that's not to say that we would ignore having a new lesion on your scan if you're 1 year on medication, but we certainly wouldn't necessarily call that a failure. But if a drug fails due to significant new disease activity, then moving to a higher efficacy drug class makes the most sense. There are now numerous studies that show if you sort of go laterally, and we did this all the time, 25 years ago, if you failed Avonex, you would go to Rebif. That's not a very logical thing in today's world, but that's what we had available 25 years ago. If a drug fails due to side effects, then switching to a different class would make sense. So for example, if you fail Gilenya due to having a problem with some side effect, changing to, say, Zeposia or Ponvory would not make much sense. You're likely to have the same side effects. But if it's also true that a drug can fail due to future risk. And in that case, for example, if you have a JC virus test that is negative, the JC virus is associated with this development of the brain infection PML, progressive multifocal leukoencephalopathy, which some of our drugs are associated with, especially Tysabri. You may be negative on that test and have no risk, but then you convert, that is, you're exposed to the virus, and that will force you to change your medication, so a switch. Or perhaps if you're on one of the CD20 drugs, such as Ocrevus or rituximab, and you're having a drop in your normal antibodies or your immunoglobulins, those are things that might be associated with future risk of infection or reactivation of infection, and that would suggest that you might change or alter your medication at that point in time. That's not really an escalation, that's really a switch, and oftentimes you would switch to a drug that has a similar level of efficacy. So we can use escalation, we still do use escalation, but the real issue is, would you use a high efficacy therapy first? And the principle of using a high efficacy therapy first is that many people will in fact fail or not tolerate the moderately effective therapies. There's the greatest need for highly effective therapies early because that's when people have most of these relapses and changes on their scan for which these drugs are best suited. The lowest risk of highly effective therapy is in younger patients. That is, younger patients tolerate everything better than older patients with regard to potential risks or side effects. And it simply just doesn't make sense to let someone accumulate more disability when you have a known more effective drugs. And these drugs have all been tested in head-to-head battles, and there's clearly differences between them. It just doesn't make sense to say, well, let's have you get more disabled, then we'll give you the better stuff. That is just not logical. So the question for us really revolves around, would you use an induction approach, which I'm going to describe in a moment, or would you use a more persistently highly effective therapy? And so what is induction therapy? This is a term that's borrowed from the cancer literature. And in their world, it's a typically first therapy. It's for a restricted period of time. And it's often bundled with other things, such as surgery. Like if you have a lung cancer or breast cancer, you might do some induction therapy, you might then do surgery, you might then do x-ray therapy, and might even do hormonal therapy. In our world, what we're looking for is something that would potentially be used as a first-line agent or very early, and then would be giving you long-lasting benefits so that you wouldn't have to use it for a prolonged period of time, and you would potentially have even permanent alterations in some parts of your immune system that would allow you to not have to be retreated or be retreated very infrequently. It's also sort of taken together with the fact that risks may be untenable if you use these persistently. And so perhaps the best example is with Novantrone or mitoxantrone, which was really not used much at all, if at all, anywhere in the world right now. You can only use it for a certain number of doses and a certain amount of the drug because it would be associated potentially with heart failure. Up to 3% of people would have heart failure if you exceeded what our limit was, and also delayed leukemia years later. And so you couldn't go over that dose because it was known to be associated with that. But in addition, there's sort of this false idea that if you use an induction agent, that somehow magically you don't ever need to be retreated. The reality is that all of the induction therapies that are presently available, in fact, are associated with some level of retreatment. And then the question is, do they really just be sort of something we'd use early, but we wouldn't be able to use persistently because of potential risks? And so these are medications that could be considered induction therapies: cladribine, Lemtrada, Novantrone, and then even a stem cell therapy, autologous hematopoietic stem cell therapy, which you're going to hear about in the next talk with Dr. Kay, and I'm not going to really talk about. All of these could be considered therapies that would be used on a short-term basis, stem cell therapy really perhaps once, and would potentially give long-lasting benefits that would not require more persistent use. In general, the risks are relatively high here, especially compared to the moderately effective therapies. The exception for that is cladribine, where the risks are not really that high. And all have some degree of failure, and that's the important part. For example, it could be up to 5% or more per year with cladribine, for example, in long-term studies. So although we think of these as potentially induction therapies that would maybe alter things permanently, you wouldn't need to be treated for a long period of time, the reality is that there's still significant retreatment issues. So in practice, given the variability of disease severity and the difficulty with that prediction when first treatment decisions are being made, really only cladribine is presently being used in this sense as a potential induction agent. And again, there is treatment failure with this, so none of these really give us the long-acting benefit in that sense that we would like to, although we'll hear what Dr. Piquet says about stem cell therapy. So our view right now is that highly effective therapy used persistently makes most sense for most newly diagnosed patients with MS, Usually this means either tisabria or one of the anti-CD20 agents, maybe some of the medications, the same class as Gilenya and Saposia, and then to adjust as needed over time.
So I think this is kind of where things stand now. Not every doctor is going to prescribe one of the more high efficacy therapies to start out with. Doctors that I saw back in the day did tend to be conservative, but like I said, we didn't even really have the options. I have to wonder if I were started on one of these higher efficacy therapies way back in the day, would it have pretty much stopped my MS in its tracks, and I wouldn't even have the disability that I have accumulated over the years. I'm just thankful that even though the only DMT I've ever been on was Copaxone, it seemed to do a good enough job, or maybe I wasn't going to go down the road to severe disability anyway. I don't know. I never will know. You can't be the control of your own experiment. And quite honestly, when I was young and just starting out with multiple sclerosis, I wasn't probably even in the best position to decide whether I would want to assume the risk of going on to a high efficacy therapy in the hopes that I would never get any worse, when I actually wasn't even feeling all that bad, and I thought, well, maybe this will go away and it'll never come back. We know how optimistic and hopeful young people can be, right? So I don't know whether I would have been in the right frame of mind to make the choice that now, as I look back on it, I think, yeah, maybe if I had done that, I would have been able to remain in the workforce. I would have been able to keep doing my long walks in the mountains. I would have been able to do a lot of things that I can't do now. I don't know. I can't make that choice. It's too late for me to make that choice. I don't know. What do you think? If you're in that same position, do you think you would have done something differently if those options had been available to you or not? I'm curious to know because it's a tough one. It really is not a decision that can be made lightly. And no matter how much encouragement you get from your doctor or don't, it's still in the long run entirely up to you. But you know what? One thing that we can do regardless is to take good care of our general health, regardless of the therapy we go on or don't go on. If we do the best job we can of managing our weight, getting some exercise, doing some movement at least, getting good sleep, keeping our stress levels down to a reasonable level, all of those things can really help us, I think, manage our MS regardless of what is going on. I'm not saying that it would be like we didn't have MS at all, but it would certainly make daily life more pleasant, or at least as pleasant as it could be. But that's all I have for you today. So until my next video, please do take really good care of yourself.